Okay, let's unpack this. Um, as endocrinologists, we periodically get consulted on, perisurgical anti-diabetic medication management. It happens quite a bit.
It really does.
And our core mission in those moments, it's always sort of twofold, right?
Mm.
Keep the patient's blood sugar stable
hmm
and make sure their essential medications aren't compromised or don't cause harm during that really critical perisurgical window.
And what's truly fascinating here, and often, frankly, incredibly challenging,
Mm.
is striking that delicate balance.
Yeah.
Especially when we're dealing with these non-insulin glucose-lowering meds. Altered food intake can just throw everything off.
Totally.
And you've got these very real risks, both hypoglycemia and hyperglycemia popping up.
Absolutely. So today we're taking a deep dive into a clinical practice guideline review. It's titled Managing Non-Insulin Glucose-Lowering Medications Before Surgery, a comparison of clinical practice guidelines.
Sounds like a mouthful, but important stuff.
Right. And our mission for you, the learner, is really to distill the critical info. We want to highlight the key recommendations for these meds and, maybe more importantly, where the guidelines sometimes diverge.
Yeah, where things aren't quite aligned.
Exactly. It's about getting you those actionable insights without having to wade through all the dense text yourself.
Makes sense.
It seems straightforward maybe on the surface, but why is preoperative medication management such a tightrope walk? Why is it so tricky?
Well, think about it. Patients going into surgery, they often have drastically altered or limited oral intake, sometimes NPO for hours, right?
Right, nothing by mouth.
And that directly messes with their blood glucose levels.
Yeah.
It just throws a big wrench into their usual medication routines.
Plus the stress of surgery itself.
Exactly. Your body's already under stress from just anticipating surgery, and then you add fasting on top of that. It creates this highly dynamic environment for blood sugar control.
That's a really good way to put it, the tightrope.
That's precisely it, isn't it? The overall goal is rigorous perioperative glycemic control. We're aiming for euglycemia, that, sweet spot of stable blood sugar.
Right.
But we're actively trying to prevent dangerous hypoglycemia, which can happen fast with too much medication when there's no food coming in. And also significant hyperglycemia, which, as we know, can lead to serious surgical complications. Things like infections, poor wound healing.
Yeah, all the things we want to avoid.
Definitely. And the challenge gets particularly acute with meds that actively stimulate insulin secretion, because they can push blood sugar down, sometimes dangerously low, when a patient isn't eating.
Okay, that makes sense.
Yeah.
And the source we're looking at today really emphasizes that because this whole landscape is so complex, that robust local institutional protocols become incredibly key. They give you that consistent framework clinicians need to navigate these, frankly, high-stakes decisions.
Absolutely.
Yeah.
Local protocols are crucial for ensuring a smoother, safer patient journey. And this brings up a critical point. What are these decisions actually based on? I mean, where do these guidelines come from?
Good question.
They aren't just arbitrary rules somebody dreamed up. They're built on, sound physical and pharmacologic considerations,
Okay.
extensive clinical experience gathered over many years, and the best available observational data we have.
So real-world evidence and experience.
Exactly. And you'll see recommendations from major bodies like the American Diabetes Association, the ADA,
Sure, everyone knows the ADA.
the Canadian Perioperative Anesthesia Consult Group, CPOC, the Association of Anesthetists of Great Britain and Ireland, that's AAGBI, and the Society for Ambulatory Anesthesia, SAMBA.
Wow. Okay, so quite a few groups weighing in.
Yeah, and each brings maybe a slightly different lens or emphasis, which is why you sometimes see these nuances or slight differences in recommendations.
Okay, so we've got multiple expert voices, sometimes with slightly different takes. What does this mean for you, the clinician, when you're actually looking at a specific medication for your patient?
That's the million-dollar question, isn't it?
Kind of. Let's try and break down the general wisdom, maybe, and then zoom in on where these recommendations might differ, give you a clearer, more practical picture.
Sounds good. When it comes to managing these medications, the approach really has to be highly individualized. You need to look at the specific drug class.
Right, not just lumping them all together.
Definitely not. You have to consider its unique mechanism of action, like how it actually works in the body. Its half-life, which tells us how long it sticks around and stays active.
Okay.
And, of course, its potential adverse effects. Each drug really has a distinct profile that dictates how it should be handled around surgery.
Gotcha. So let's start with the big one, metformin. Often the first line, the real workhorse for type 2 diabetes.
The classic.
From what I recall, it primarily works by reducing hepatic glucose production, basically telling the liver to chill out on making sugar.
Yep, that's a key part.
And also boosting insulin sensitivity, right? Making the body's cells more responsive.
Correct. But even with metformin, the go-to drug, there are those well-known potential GI side effects, nausea, diarrhea, and that rare but still serious concern of lactic acidosis,
Right.
especially if kidney function is reduced.
Right, the EGFR concern. So what are the guidelines actually saying about holding this one? Is it straightforward?
Well, you'd think so, but even for metformin, there are nuances. It can be a point of confusion sometimes.
Oh, okay.
Some guidelines, including the ADA, generally lean towards just withdrawing it on the actual day of surgery. Pretty simple.
Okay.
However, others, particularly if the patient's EGFR is less than 60, or maybe they're having a procedure where kidney stress is expected, like with contrast dye,
Right, yeah.
they recommend holding it 24 to even 48 hours before surgery. A bit more cautious.
Interesting. So there's some variability there already.
There is, and Cleveland Clinic-specific guideline, just as an example, advises withdrawing metformin on the day of surgery. So they align more with that simpler approach in their context.
Okay. Good to know. Next up, let's group sulfonylureas like glipizide, glyburide, and the meglitinides like reproglenide, nataglinide.
The socratagogues.
Right. Both classes essentially stimulate the pancreas to release more insulin. The key difference I always remember is that meglitinides have a much shorter half-life, like an hour or so.
Yeah, around an hour. Versus sulfonylureas, which can be 2 to 10 hours. So meglitinides act fast and clear fast.
So what's the critical consideration for these guys preoperatively?
The common thread here, and this is absolutely crucial to remember, is the high risk of hypoglycemia, especially after fasting.
Makes sense. More insulin, no food.
Exactly. Because these drugs actively increase insulin, if a patient isn't eating, their blood sugar can plummet dangerously low.
Yikes.
So the general consensus across pretty much all guidelines is to hold these medications on the morning of surgery, particularly if the patient isn't expected to eat.
Okay, hold the morning dose.
Hold the morning dose. Some guidelines even get specific and say hold both doses if they take it twice daily. It's all about preventing that critical risk.
Yeah.
You definitely don't want someone crashing from low blood sugar right before their operation.
Absolutely not. Okay, now moving to a really fascinating class. The SGLT2 inhibitors.
Yes. The flavlizins.
Right. Canagliflozin, dapagliflozin, empagliflozin, utugliflozin. Their mechanism is pretty cool, working in the kidneys to block glucose reabsorption.
Making you pee out excess sugar, essentially.
Exactly. But here's the big critical catch. They carry that risk of volume depletion,
Dehydration risk.
low blood pressure, and then the really scary one, euglycemic diabetic ketoacidosis. DKA, but with normal sugars.
That's the one that catches people off guard. Euglycemic DKA. It's a real game changer for management.
It sounds like it. So how do the guidelines handle these?
Well, given that risk of DKA, which can be a severe and quite unexpected complication,
Right.
this class actually has a more consistent recommendation across guidelines than some of the others we've talked about.
Oh, okay.
That's helpful.
Yeah. For instance, the US FDA recommends holding SGLT2 inhibitors at least 3 days before surgery.
3 days. Okay.
And ertugliflozin specifically, they advise holding 4 days prior, just because it has a slightly longer half-life.
Got it. 3 days mostly, 4 for ertugliflozin.
Pretty much.
Yeah.
And Cleveland Clinic aligns with that, hold them 3 days preoperatively or 4 days for ertugliflozin.
So, good alignment there.
Yes, this broad consensus is really about minimizing that DKA risk, which, as you mentioned, is particularly tricky because it doesn't always show up with the super high blood sugars we typically associate with DKA.
Yeah, that euglycemic part is key. That consistency is helpful, especially with something potentially so serious.
Agreed.
Now, let's talk GLP-1 receptor agonists, things like liraglutide, semaglutide, dulaglutide, and also the dual GIP-GLP-1 agonist tirzepatide.
The incretin mimetics. Very powerful agents.
They really are. They mimic natural gut hormones, promote glucose-dependent insulin secretion, and famously, they slow gastric emptying.
Right, that's a big part of how they work. But that slowed gastric emptying, while good for glucose and weight, can be a real concern perioperatively, right? Especially thinking about aspiration risk during anesthesia.
Absolutely. The potential for stomach contents to be inhaled into the lungs is a major worry for anesthesiologists.
So how are these handled? Is there consistency here?
This class, interestingly, sees a fair bit of variation in the recommendations. It kind of reflects the evolving understanding of how best to manage them around surgery.
Okay, so more divergence here.
Yeah. For oral semaglutide, which has a really long half-life, it's pretty widely recommended to hold it 7 days before surgery.
A full week. Wow.
A full week. For the weekly injectable GLP-1 agonists, like dulaglutide or injectable semaglutide, they're often held 5 days prior, according to some guidelines.
Okay, 5 days for the weekly shots.
But then other guidelines offer no specific recommendation at all.
Really? None?
None specific. While some others suggest maybe continuing daily injections if the patient doesn't have nausea or vomiting, or holding the weekly injectables just the week before surgery. So you see the variation.
Yeah, that's quite a range. What about Cleveland Clinic?
Their current guideline advises holding the dose the week before surgery for those weekly GLP-1 RAs, primarily to mitigate that aspiration risk we talked about.
Okay.
It really highlights the challenges, when guidelines haven't fully converged on a single approach yet.
It definitely does. Okay, finally, let's briefly touch on DPP-4 inhibitors, sitagliptin, linagliptin, those guys, and thiazolidinediones, or TZDs, like pioglitazone.
Right. 2 other classes to cover.
DPP-4 inhibitors, they're generally pretty well tolerated, right? They work by increasing incretin hormones.
Correct. They boost your body's natural incretins.
And then TZDs improve insulin sensitivity, making cells use insulin better.
Yep. Work on insulin resistance.
And importantly, both classes tend to have a lower risk of hypoglycemia compared to, say, the sulfonylureas.
That's a key point. Lower intrinsic hyporisk.
So does that make them easier to manage pre-op?
Generally, yes. Because of that lower hypoglycemia risk, the consensus for DPP-4 inhibitors is often just to continue them as normal, even on the day of surgery.
Oh, okay. So continue DPP-4s.
Usually.
Yeah.
Makes them relatively straightforward. For TZDs, there's a little more variation again. Some recommendations suggest holding them on the day of surgery,
Okay.
while others might advise continuing them as normal. So maybe minor discrepancies, but generally a less restrictive approach compared to some of the others we've discussed.
Got it. And just a quick mention, alpha-glucosidase inhibitors like acarbose,
Carbose.
they block carbohydrate absorption in the gut. Main side effect profile seems to be gas and diarrhea.
Pretty much their main party trick, as you said.
Yeah.
Given their mechanism, which is tied directly to eating carbs
Right.
and those GI side effects,
Mm.
the Cleveland Clinic recommends holding them on the morning of surgery.
Makes sense.
Other guidelines agree, especially if the patient isn't going to eat a morning meal. Their whole point is to reduce post-meal glucose spikes.
So if there's no meal...
There's no point in taking it.
Yeah.
It just doesn't make sense.
Okay, that covers the main classes.
So if we pull back for a second, what does all this individual drug management tell us about the bigger picture?
Yeah, what's the takeaway?
Well, it's clear that managing these non-insulin glucose-lowering meds is absolutely not a one-size-fits-all deal.
Definitely not.
There are nuances, complexities, and as we've seen pretty clearly, even discrepancies between different expert guidelines.
For sure.
And this really just highlights the critical role of individualized patient assessment. You have to consider their specific medication, any other health conditions, comorbidities, and the exact type of surgery they're having. It's all about tailoring the plan to that unique patient situation.
I remember a case once, actually, where a patient on a weekly GLP-1 had their surgery unexpectedly moved up by a few days.
Oh, wow.
And we had to scramble, pivot really quickly from the standard holding period to make sure they were safe regarding that aspiration risk.
Exactly. That kind of thing happens.
Right.
It really drives home the need for flexibility and just sharp clinical assessment in the moment.
That's a stark reminder of the stakes involved. Ultimately, it all comes back down to minimizing the risk of complications, doesn't it?
Absolutely.
Whether it's avoiding a dangerous hypoglycemic event that could affect the brain, or ensuring stable blood sugars to prevent surgical site infections or poor healing.
It's truly about patient safety. That's the bottom line.
So what's the core message for you, the listener, wading through this complex landscape?
Well, I think it's not just about memorizing every single drug-specific rule, though knowing them is important.
Right.
It's more about understanding why these guidelines exist, appreciating the critical risks like DKA with SGLT2s, hypoglycemia with secretagogues, aspiration with GLP-1s.
Understanding the why behind the what.
Precisely. And then leaning heavily on those robust local protocols we talked about.
Yeah, back to the local protocols.
Yes. Your own institutional guidelines really become your most reliable compass in practice. They should be designed to bridge those discrepancies we highlighted across the different national and international bodies, providing clear guidance for your setting.
That makes a lot of sense.
Yeah.
Rely on your local team and agreed upon protocols.
Exactly. The real insight here, I think, is that while these national guidelines provide a vital framework, effective perioperative care really demands a proactive, individualized approach.
Okay.
And that hinges on prioritizing clear communication within your surgical and anesthesia teams, and really adhering to those established local protocols.
So teamwork and local guidance are key.
Couldn't agree more. And maybe this raises an important question for you to ponder as you go back to your practice.
Okay.
In your specific surgical setting, how can you and your team proactively contribute to strengthening those interdisciplinary protocols? How can you improve those communication channels to ensure optimal patient outcomes, really bridging any remaining gaps between these sometimes diverse expert recommendations? Something to think about.